Hi, welcome to Medhustle's high-yield Harrison-based videos. So today we will have a discussion on Guillain-Barre syndrome. So before leading into the topic proper, let us discuss a case scenario. So this patient was a 28-year-old female with no comorbidities. She came with the complaints of tingling bilateral lower limbs since 1 week, bilateral lower limb weakness since 5 days, and bilateral upper limb weakness since the last 3 days. Since the last 2 days, she also had shortness of breath. So, with this history, on evaluation, we found out that the patient's both bilateral lower limb reflexes were absent. And the power of her lower limbs was 0. Also, on further evaluation of the cranial nerves, it was found that she was having bilateral element type of facial palsy. So now, coming to GBS proper. GBS, also known as Guillain-Barre syndrome or the Landry-Guillain-Barre syndrome, the most common subtype of which is AIDP. That is acute inflammatory demyelinating polyradiculoneuropathy. Polyradiculoneuropathy means both motor and sensory fibers are affected. So GBS typically has symmetrical weakness of both usually lower limbs or upper limbs. And as discussed in our case scenario, it is an ascending type of weakness, wherein usually the lower limbs get affected first, and then the weakness progresses to involve the upper limbs, the respiratory muscles, the neck muscles, the facial muscles, and all these things. And mainly, the proximal muscles are involved more than the distal muscles. Proximal muscles of the lower limbs, like the thighs, and upper limbs are the arms and the shoulder muscles. So now, coming to ascending paralysis differentials. So once a patient with ascending paralysis comes to us, we need to rule out certain things. So ascending paralysis can be seen in GBS. It can be seen in porphyria. Now remember, in porphyria, usually the history of weakness is a recurrent kind of weakness. Apart from that, the patients usually have abdominal pain and neuropsychiatric manifestations like change in the behavior. Sometimes they can present with seizures or these things, and ascending type of paralysis. Another differential is Lyme's disease caused by Borrelia. Remember, Lyme's disease is important because this infection also causes bilateral element type of facial palsy. Now, to finish, one more important topic here is the differentials for descending paralysis. And this can be remembered with the mnemonic DBT, which stands for diphtheria, botulism, and T for tetanus. So these are the causes for descending paralysis. Now, Guillain-Barre syndrome, also known as Landry-Guillain-Barre syndrome. The antibodies which are present in GBS and the various subtypes. So this slide particularly, I want you guys to pay attention for like 5 minutes, so you'll be in a better position. So what this A figure is your typical subtype of GBS, which is AIDP. So as we all know, this is a typical neuron. So for that matter, let's consider this as your motor neuron. Okay, so this part we know, axonal part, and this is your myelin sheath. Okay, around the nerves. So this is the myelin sheath. So what happens in GBS is, typically, if you have to remember, is what happens is certain infections, usually GI tract infections and respiratory tract infections. So these infections act as some triggers, okay? And usually these infections are present 1 to 4 weeks before the GBS affects the patient. So 1 to 4 weeks before the patient will have some GI or respiratory tract infection. So which are those trigger infections? I'll tell you in the subsequent slides, but just remember, because of some trigger infections, what happens is the body start producing, the immunity is activated, the immune cells. And when immunity gets activated, what happens is your T helper cells and your B cells, they both get activated. And these B cells, they start producing antibodies. And these antibodies, what happens is, as you can see an antibody photo here. These antibodies, they start going and hitting your nerve, motor neurons or your sensory neurons, whichever type of GBS the patient has, which I'll teach you in the subsequent slides. What happens is these antibodies, they're going to go and affect typically your myelin sheaths. So the myelin around the nerves, it is going to affect. So this is what happens typically in AIDP, wherein these antibodies are not named. So you don't have to remember any particular antibody for AIDP type. So these antibodies, they go and affect your myelin sheaths. Vis-a-vis, now we are going to discuss something about two other common variants of GBS known as AMAN and AMSAN. So very, very important is you should know the variants of GBS, which they'll ask you in all your exams. So there are some common variants and there are some rarer variants. So that also we'll discuss in the subsequent slides. So common variants are AIDP, that is acute inflammatory demyelinating polyradiculopathy. Then there is your AMAN. What does AMAN stand for? Acute motor axonal neuropathy. What does AMSAN stand for? Acute motor sensory axonal neuropathy. Simple meaning, motor axonal, it mainly affects your motor neurons. Motor sensory, it affects both your neurons. Okay. So what happens typically in AMAN variant is, as you can see, again, see this diagram. Just have a pictorial memory of this diagram now. So what happens is once these antibodies get formed, they typically affect certain portions on your neurons. As you remember from your physio days, these are your nodes of Ranvier. And why these nodes of Ranvier are important? Because remember from your physio days, what happens is once a transmission starts in the neurons, it jumps around these nodes of Ranvier and there is fast conduction of transmission. So this is what we call is saltatory conduction. This is from your physio, just an integrated thing over here. So what happens is in AMAN and AMSAN, typically there are certain portions, certain gangliosides. If you want to know the name of these things, these gangliosides are GM1 and GD1A. So why these are important, I'll teach you in the subsequent slides. But just remember in AMAN and AMSAN, you have to remember these two gangliosides which are present at the nodes of Ranvier. So these antibodies are going to go and hit your gangliosides which are present at the nodes of Ranvier. If you want to know the names are GM1 and GD1A. And that is why this saltatory conduction won't happen. And that is why there will be no nerve transmission, no action potential transmission along the nerves. And that is why the patient will have features of muscle weakness. Your directly myelin sheaths were getting affected in AIDP, whereas in AMAN and AMSAN, the gangliosides typically at the nodes of Ranvier get affected. So GBS is a very important question which will be asked in your NEET, in USMLE, MRCP, in your internal medicine residency also. So what you can do is, if the question comes, you can draw this diagram and you can explain the saltatory conduction and the nodes of Ranvier. So this is nothing but again the same thing. I'm discussing AIDP. I told you certain infections. So this reference is from Bradley's book of neurology, super specialty book. Okay, so certain infections I told you, which infections I'll tell you now, GI infections and certain respiratory infections. So they activate your T cells and your B cells. So your T cells, we know they produce certain cytokines, and because of that, they're going to go and hit your, mainly they're going to affect your myelin. And along with that, these B cells are going to produce antibodies and they're going to go and affect your myelin. Vis-a-vis now coming to AMAN variant or AMSAN variant, I told you both these things will get activated after infections. And typically Aman will go and affect your GM1 epitope or the GM1 ganglioside, which is present at the nodes of Ranvier. See, they've shown a GM1 epitope beautifully in this figure. So the GM1 epitope at the nodes of Ranvier will get affected. Okay. Whereas in Amsan, it typically affects GD1A. So now, as I told you, we need to remember certain variants. So as I told you, this is AIDP, the most common variant. The antibody, typical antibody, there is no name for that antibody. Okay. For Aman and Amsan, what you have to remember is GM1 antibodies and GD1A antibodies, as we have seen in the diagram. Okay. Now, there are certain variants which are rare, but one of the most rare variant which they love to ask in your exams is your Miller-Fischer syndrome. So Miller-Fischer syndrome is a very important thing to know. It is a variant of GBS and it goes by a triad. So what is a triad? They will ask you in your exams. So the triad is ophthalmoplegia, ataxia, and areflexia. So remember what happens in GBS is we get areflexia of all the reflexes usually. Of the muscles which get affected, we get areflexia in GBS as well. But usually ophthalmoplegia and ataxia, these features are not present in GBS. Because just remember, GBS most common subtype is AIDP. Okay, AIDP or GBS per se most common type. The cranial nerve which get affected, the most common is facial nerve. So in clinical features, I'll discuss this in a greater detail. But what happens in ophthalmoplegia, the cranial nerve which gets affected are your upper cranial nerves typically. So that is why the patient has ophthalmoplegia, ataxia, and areflexia. This is a typical triad of Miller-Fischer syndrome. And the antibody, the ganglioside which gets affected, there is a particular name for that ganglioside, that is GQ1B. Okay, so you have to know this antibody name. Just a second, sorry for this. GQ1B antibodies. So now to recapitulate, let's discuss AIDP. There is no name for its antibody. Aman, Amsan, I told you the names of those antibodies. Which are those antibodies? GM1 and which is the other antibody? It is GD1A. So these antibodies are for Aman and Amsan. And for Miller-Fischer syndrome, the triad is ophthalmoplegia, ataxia, areflexia. The antibody is GQ1B. So they are very fond of asking these antibodies in your exam. So you have to know these antibodies. And for this pictorial diagram will help you. So GM1 and GD1A for Aman and Amsan, and for Miller-Fischer, GQ1B antibodies. Okay. And antecedent infections, as I told you, certain infections occur 1 to 4 weeks prior to the onset of GBS. And most common infection is, again, this will be asked a lot of times in your exams, Campylobacter jejuni infection. So this usually is responsible for your diarrheal illnesses. So C. jejuni infection. Apart from that, certain respiratory infections like Mycoplasma pneumoniae. Apart from that, other infections like CMV, EBV also have a role. Now remember, very important thing about vaccinations. So a lot of study has been done. H1N1 vaccine and old rabies vaccine typically are known to cause GBS. Old rabies vaccine, the neuro rabies vaccine, like the vaccines which are brain cells were used. So those vaccines typically, and very, very important these days, they are very fond of asking two infections now, Zika virus infection, and last but not the least, COVID is associated a lot with GBS. A lot of reports have been done where a patient has COVID and he develops GBS a few days later. So these antecedent infections, you should know. Of that, if you ask me which infection you don't have to forget, you don't have to forget C. jejuni infection at all, because that's the most common infection. Okay. But what happens is, once we start taking history of these patients and we ask if he has had diarrhea, if he has had any sore throat, cough, cold a few days before, these infections are so mild in these patients sometimes, they have no memory of these infections. So usually these infections are very mild in some patients and we can miss these infections, but you should know which antecedent infections can cause GBS. Okay, so we are done with infections. Now coming to the clinical features. As I told in the initial parts of the lecture, there is typically ascending kind of a paralysis, ascending flaccid paralysis. And the paralysis is typically symmetrical. Proximal muscles are involved more than your distal muscles. So we'll make 3 parts of this. So this is about the paralysis. Apart from that, sensory fibers can also get affected. That is, a patient can have features of tingling, parasthesias. Apart from that, patient autonomic nervous system can get affected. That's why you can get features of orthostatic hypotension and all those things. So that is why checking for orthostatic hypotension and all those things is very important in these patients. Apart from that, cranial nerves typically can get affected. And most common cranial nerve to get affected is your 7th nerve, that is your facial nerve. And usually it is a bilateral element kind of a facial palsy. Now, very important is the examiners are very fond of asking which are the other things where you get a bilateral element facial palsy. So to answer that, one is Lyme's disease, and sarcoidosis is another infection which causes a bilateral element kind of a facial palsy. So in your NEET or in your other exams or even in your vivas, they might ask you all are associated with bilateral element facial palsy except. So typically they'll give in the questions GBS, Lyme disease, and sarcoidosis. And also leprosy can cause a bilateral element kind of a facial palsy. Okay, so cranial nerves. So these are all the clinical features of GBS. And according to the variants, Aman causes a pure motor kind of a paralysis. Amsan causes both. And I discussed already about the Miller-Fischer syndrome, where you get a typical triad of ophthalmoplegia, wherein the patient will complain of double vision, diplopia, and all those things. So in the question, always read about these things. Once we discuss about stroke and the individual cranial nerves in the subsequent classes, I'll teach about ophthalmoplegia in a greater detail. Areflexia and ataxia, wherein the patient says that he'll sway to a particular side while walking or something like that. So this is a triad of Miller-Fischer syndrome. So it is very easy. You just have to remember these parts. It is ascending kind of a flaccid paralysis, symmetrical weakness usually of the limbs, where proximal more than distal involvement is there of the muscles. Sensory, the patient can have tingling parasthesias. Autonomic involvement can be there. Cranial nerves, most commonly cranial nerve 7th is involved. Bilateral element kind of a facial palsy is seen. This is seen in around 50% of the cases in our Landry GBS. And other places where we get a bilateral element facial palsy is Lyme's disease and sarcoidosis. Apart from that, I told you the triad of Miller-Fischer syndrome and Miller-Fischer syndrome antibodies, GQ1. Star MCQ. Coming to the variants, and you have to remember these variants because for NEET students, if you remember only these 4 variants, it is enough. For our internal medicine students, you have to know certain more detail. So you have to remember these other variants also. So you have to remember AIDP, which I already discussed, acute inflammatory demyelinating polyradiculopathy, neuropathy, Aman, Amsan, Miller-Fischer. Apart from that, which other variants you have to remember is pharyngeal cervical brachial variant, where only your pharyngeal, cervical, and branchial muscles will get involved. There is one variant, multiple cranial neuropathy variant, wherein not just your 7th nerve, other cranial nerves like your 9th, 10th, the lower cranial nerves typically. So these multiple cranial nerves can get involved. Facial diaplegia with parasthesias, wherein only your patient has only facial diaplegia, that is element palsy of your bilateral facial nerves, and just patient has parasthesias. Only paraparetic variant, wherein the patient says that he just has weakness of the lower limbs, ascending kind of a weakness, and your upper limbs are not involved. And this is a very dangerous condition to have. Acute pan-dysautonomia. So this table is again from Bradley's, but it is needed for you guys because Harrison is lacking in a few of the things. So those things need to be added up. So acute pan-dysautonomia means the patient just has severe autonomic dysfunction. Just has autonomic dysfunction. So it is very difficult to catch up this variant, acute pan-dysautonomia. And apart from that, there is just one ataxic variant. So just to recapitulate again, these are the common variants. Miller-Fischer is also a rare variant, but you can consider it as a common variant because they like to ask about these 4 variants. But other variants which you have to remember is pharyngeal cervical brachial variant, multiple cranial neuropathy variant, facial diaplegia with parasthesias, paraparetic variant, acute pan-dysautonomia, and acute ataxic neuropathy. So these are the other variants of GBS. Coming to the investigations. Now, very, very important to know is about the investigations. You have to remember 2 investigations. You have to remember CSF and you have to remember nerve conduction studies. So CSF usually comes positive after a week. So what happens is, this happens a lot in clinical practice also. We see a patient and he's had weakness since 2 days or he's had weakness since 1 day, this typical kind of a presentation, and we do a CSF and CSF is normal. And that is why we are in a fix, because if CSF is normal, we think it is not GBS, but what happens is CSF usually comes positive after a week. So always what we do is, even if we do a CSF now, we usually advise a CSF after a week again. And what do we see typically in CSF? What they will give you in your questions is something known as albumino cytological dissociation. So what does albuminocytological dissociation mean? It means there will be more of proteins in your CSF, simple terms, and cytological, that means less of cells. So typically the CSF will be rich in proteins and cells are usually less than 10. Okay, if you want to remember a number, usually the cells are less than 10 or there are no cells in the CSF typically. And why there are loss of proteins? Because once these myelin sheets and your nodes of Ranvier, they get affected, these are nothing but your muscle proteins which get broken down. They start coming down in your CSF. And that is why you get a lot of proteins in your CSF. So you get typically something known as albuminocytological dissociation. There are no cells or the cells are less than 10, whereas the protein count is very rich. Okay, so it is known as albuminocytological dissociation. Now remember, this albuminocytological dissociation is a misnomer again, because the protein which is actually high in the CSF is globulin, not albumin. Okay, that is why it is a misnomer. Actually, it is a globulinocytological dissociation, but they don't write it that way. We always write it as albuminocytological dissociation. Okay, and in nerve conduction study, obviously, what will happen is, because there will be a lot of damage to these nerves, so there will be decreased amplitude of the action potential, increased latency. What does increased latency mean? That is, there will be more time needed for the action potential to travel across the nerves. And very, very important thing to remember is there is something known as F wave latency or F wave potential. It will be increased. Now, what is this F wave? Now, to make this as an easy thing to remember, consider this as a hand of a patient. This as the spinal cord of the patient. What happens is the signals come to the hand. We get a flickering of a movement. Usually once, if we have to move our hand, signals come and they go back and we have movement. So what does this F wave mean? What happens in the checking for this nerve conduction studies? What we do is we usually insert pins and we check for which variant or which neuropathy is it of the patient is having. So what does F wave latency mean is, once we stimulate this, what happens is the nerve conduction goes from here. But because the nerves are damaged, there is polyradicular neuropathy, multiple nerve roots are affected. What happens is there is increase in the wave latency period because the signal travels, but for it to come back again, there is increase in that time. So that is known as increased F wave latency, and this is the earliest finding which is seen in GBS. So earliest finding in GBS is increase in the F wave latency. There is decreased amplitude, obviously because nerve action potentials are not traveling. That is why the amplitude will be dampened, and increased latency. And in CSF, what we get is typically Albuminosatological Dissociation, wherein the proteins will be more and cells will be typically less than 10. Now, these are not the clinical features. There are certain criteria for GBS. You just have to know the names of these criteria. So the criteria typically are, this is known as your Brighton's criteria. And there was one more criteria initially known as Ashbury's criteria. So you don't have to know what is in detail given in the criteria. Okay, you just have to know the name of the criteria. So the name of the criteria is Brighton's criteria. Okay, just to make you aware what is there inside the criteria, I'll just tell you. It has certain things which are clinical and certain things which are there in the labs, and this is a diagnosis of exclusion. So clinically, as I told you, there is bilateral, usually flaccid weakness of the limbs, decrease or absent deep tendon reflexes, and usually the onset to nadir, that is the plateau of the weakness, usually reaches in up to 28 days. So in GBS, very, very important is usually within 4 weeks, the weakness is complete. 28 days or 4 weeks, you have to remember. Okay. So from the onset to the nadir, usually in GBS, the weakness is complete. So this is the clinical features. The CSF features, again, I told you, cell count is usually less than 50, typically less than 10. Easy way to remember. Proteins are high, and nerve conduction findings are consistent. The nerve conduction findings I already told you. So the same thing, there's 2 things about CSF and one thing about nerve conduction study, and absence of alternative diagnosis or weakness, wherein you don't think that any other diagnosis is present. So how do they make it? Clinical criteria plus exclusion is there. That is, this and this is there. And we just check for our 2 investigations. That is nerve conduction study and CSF. So if both are positive, it means level 1. If one of them is positive, it means level 2. And if we couldn't do both, only clinically we think that the patient is having GBS, it means level 3. So these are the 3 levels of Brighton criteria. Where clinically you think the patient is having GBS, only clinically, that is level 3. Clinically plus either your nerve conduction study or your CSF is positive, that means level 2. Both the investigations are positive, that means level 1. Management is very easy. So once you diagnose the patient is having on your CSF nerve conduction study clinically, you usually start these patients on either IVIG or plasmapheresis. Now, which is better? If somebody asks you a question like that, which is better? So none of them has proven to be more superior to the other. That should be your answer. Okay. But in Indian scenarios, typically we use IVIG. Okay. And what is the dose of IVIG? It is 2 grams per kg in 5 divided doses. So we give this over 5 days typically to the patient, 2 grams per kg. Okay, that is it. If you have to remember about GBS. And apart from that, you have to monitor the patient if he's having respiratory distress or if he's landing into pulmonary embolism, because these patients are going to be bedridden for a long time. And